Good afternoon or good morning. Welcome to our webinar for patients. Questions I'd like to ask my doctor. This is a very peculiar webinar because today our experts don't have presentations. They will just answer your questions. And before this webinar, we asked patients to submit their questions. And during our webinar today, we have a group of doctors experienced in thymic tumors, and I think I noticed that all of them managed to join. So Professor Joshua Sonett, thoracic surgeon from NewYork-Presbyterian Columbia University Medical Center, New York, USA. Hello, Josh.
Hello, glad to be here.
Professor Arun Rajan, medical oncologist from the National Cancer Institute, National Institute of Health, Bethesda, USA. Hello, Arun.
Hello, Margaret. Thank you for the invitation.
Professor Andreas Rimner. I'm not sure if Andreas has joined.
I just did.
Oh, great. Professor Rimner is a radiation oncologist from Memorial Sloan Kettering Cancer Center from New York, USA. Great that you could join. Professor Edith Marom, diagnostic radiologist from the Chaim Sheba Medical Center, Ramat, Israel. Hello, Edith. And my name is Małgorzata Szołkowska. I'm a pathologist from Poland. I work in the Institute of Tuberculosis and Lung Diseases. So as I told you before, we asked patients for questions. They are interested to hear their doctor's answer, and we received a lot of very interesting questions. So we will try to answer them, or at least as many of them as possible. Okay, so let's start. So this is the case of, or the first question. The question is from the patient who was diagnosed with thymoma type B1 and stage Masaoka 2B. Margins were clear, but small, 1 millimeter. And oncologists decided radiotherapy was not required. And the question is, given the very small margins, the stage and type, so B1, stage Masaoka 2B, would radiotherapy be advised or not? What is your opinion?
I guess that question is for me.
Yes, Andreas, you can, of course, you can start.
All right, so radiation therapy can be given after successful surgery and or chemotherapy. And it's mostly driven by the margin status and the stage more than the WHO type. Just going, one by one, the margin status is generally a strong indicator for radiation. Essentially, if the margin is either positive, meaning there are tumor cells at the edge of where the surgeon cut, that would be lead to a strong suspicion that there are potentially cells that are left behind on the other side of that cutting edge, which would still be in the patient. And therefore, if there are cells left behind, radiation can target those and eradicate them, and by doing so, reduce the risk of a recurrence. If the margins are close, which seems to be the case here, it's a little bit less strong of an indication, although most radiation oncologists would probably still recommend it. And we actually do have data now that people do live longer and have less recurrences if we add radiation to surgery in the setting of close margins. If there's completely negative margins, meaning the surgeon removed everything with good safety margin, even there is a potential role for radiation. And the data is a little bit more clear for the more advanced stages like 3 and 4A. Stage 2 is a little bit more controversial. 2B, there's a little bit more data on than for 2A, but essentially the more advanced a thymoma is, the more of a role for radiation there is. We in ITMIG have actually published the largest study on stage 2 thymoma that was completely removed. And there still was a small survival benefit in the people who got surgery and radiation compared to those who got surgery alone. So it's always a discussion with a patient. It's a discussion with a surgeon that's really important to know exactly where the margin was. Did the surgeon feel it came out really easily and they feel very comfortable with the margin? But if there's a question, then that would be something where we would strongly consider radiation. That is correct.
Yeah, I mean, can I just add that I'm sure your surgeon and radiation oncologist and pathologist are working together, because the question is that 0.1 millimeter margin, which basically is almost functionally not a margin, was that near where the tumor was cut, or was it just on the outside of the tumor that was poking out of the thymus, and you can't get a bigger margin by virtue because it wasn't touching anything? And that's a critical question that we can't answer looking at this, but your team most certainly would understand and factor that in. Wouldn't you agree?
Yes, absolutely.
Okay, thank you. So next question. Sometimes questions are very similar. So if you think you don't have anything to add, we can skip the question. However, please consider maybe you would like to add something. Here is a little bit maybe similar question. However, the beginning is associated with something completely different. So there is a question. I have yearly CT scans. What are the benefits of CT scans versus MRI? What are the recommendations to monitor for thymoma recurrence? And before we go further, Edith, would you like to comment on that?
Sure.
Benefits of CT versus MRI.
Sure. So I hope you see that you see my screen now. Okay.
Yes, yes.
So basically, we don't use chest films because we only see big things. Hold on one second. Why isn't this moving? Okay. Okay. We don't use chest films because we're basically taking a 3D object and putting the X-ray through the patient. So we only see big masses, and it's difficult to see the normal thymic gland that way. And whoops, sorry. And because of that, wow, my scan is not moving nicely. Okay, so only big things like this. So to see the metastatic disease on the follow-up when it's small and we can still do something and affect patient management is difficult. And because of that, we will do a CT, which basically slices the patient into slices. So we can see inside, just like we can see here, that there are little dots because this is bread with grains and not just white bread. Similar to that, that's what we do with the body. And then we can see all the details. Now, the MRI scan is very similar in appearance, but it doesn't work with radiation. It works with magnetic waves. I'm not going to go into how it does it, but there's a major difference between the CT and MRI, and that's the point. This is a CT scan. This happens to be the brain. I'll show you in a second. The CT has very good spatial resolution and seeing tiny dots one next to the other, whereas the MRI has great color resolution or contrast resolution. So it's very difficult, for example, to see the mass here in the brain, and more easy to see because the differences in color to the surrounding with MRI. And that is very similar to CT. So this is a thymic carcinoma patient, which has a lot of metastatic disease in the pleura. And we thought that was it. We missed something else. And the MRI saved us because we saw on the MRI, you can see here that the bone here, the scapula, the color is white. Whereas on CT, it's very difficult to see that there's a little bit of tumor eating out the bone here. That's the contrast resolution, the color. But that comes with a price, because with MRI, when we follow, we don't have good spatial resolution. So notice the CT here where you see the lungs, you see many, many fine lungs with lines. You don't see that on the MRI. This is the MRI. When the pulmonary metastasis is large, because of the color, we will be able to see it, but we won't be able to see fine details in the lungs, for example. So when is the MRI good? It's good when we follow for resolution of issues like when we have something that we think is a recurrence and we think maybe it could be fluid and not a recurrence, if there is a question like that asked, instead of going straight to surgery to prevent unnecessary surgery, we sometimes may ask for an MRI to answer that question, as we did here, and we saw this was all white, this was fluid. So I'm going to stop sharing now. So that's my point, that MRI is good for problem solving. And sometimes on the follow-up, if patients don't want radiation every year, it depends on their age really, when they're younger, every year for many, many years, sometimes instead of the recommendations where we normally, after 5 years, if the tumor is early and not very aggressive, sometimes the routine recommendations are to alternate sometimes chest radiograph with CT. Well, those recommendations were old. Sometimes some people may opt to do once an MRI, once a CT to get the advantage of both. But most people, most areas will do a CT once we're out of the early years where most recurrences are, and we'll do annual CT scans. Annual CT scans are fast and easy, and an MRI scan is long and claustrophobic.
Mm-hmm. Thank you so much. I hope you can see the question. You can see my screen. Okay, great. And the second part of this question, this time it was B2 thymoma. Margin was also small, less than 1 millimeter. Tumor was not encapsulated, invaded fatty tissue, but not other organs. And again, question about radiotherapy. Andreas, do you think you can add something, or we can skip this question?
Yeah, I think this is a very similar scenario to the previous one. The only other thing that I wanted to add from the previous one, it said that surgery was in January and it's the end of May. In an ideal world, we like to deliver post-operative radiation within 3 months from surgery, just because when, after adequate healing, of course, so about 4 to 12 weeks or so is sort of the ideal window for post-operative radiation. So enough healing from surgery, but not enough time for anything to grow back, or that's when the radiation has the best chance to kill any microscopic cells.
Okay. Are there any recommendations to prevent recurrence? For example, diet, lifestyle, etc. Questions to all clinicians. Do you have any information about that?
I would say, this is Arun. So I would say that there is no objective evidence in that regard to suggest anything other than just maintaining a healthy lifestyle is what I would say. And then just a quick word about the role of chemotherapy in the post-operative setting in a situation like this, an early stage thymoma, which is completely resected, albeit with close margins. The short answer is we do not think post-operative chemotherapy has a role in this case, and it generally does not. In most cases, we tend to use chemotherapy upfront.
Okay, thank you. And what is the prognosis in this case? I'm not sure if what we have tumor subtype, and we don't have precisely the stage. Perhaps it was not so high. Can you propose prognosis in this case?
Yeah, so as Andreas mentioned earlier, a lot of the prognostic information is derived from the stage, also the WHO histology. B2 thymomas are generally in the good prognostic category. And as you mentioned, Margaret, this sounds like an early stage thymoma, certainly a stage 2 at least, with fatty invasion into fatty tissue. If that is the case, it's a stage 2 B2 thymoma, I would say the prognosis in general is excellent. Some numbers associated with this category are, the rate of relapse, and typically we use a certain time frame. So if you look at the 10-year mark and look at the rate of relapse, it's less than 10%. It's about 8%, which is fairly low. And if you look at overall survival, and again, we use these landmarks, So if you look at the 10-year time point, it's upwards of 80-85%. So basically, those numbers suggest that this would be in an excellent prognostic category.
Thank you. Next question, what is the best imaging option for monitoring metastatic disease? PET scans seem so open to misinterpretation. Is CT or MRI better, or should it be a combination? Edith, would you like to add something, maybe something
Sure.
about
Yes.
PET CT?
Yes. So we have to understand, first of all, what is PET? Now, I can share my screen maybe again.
Okay.
So what PET is basically, it's a combination of an exam. The machine looks just from the outside, just like a CT or MRI machine. One lays down in here and goes inside. But what it does inside, it does two things. On the one hand, a CT scan is taken. And on the other hand, a PET scan is taken. What PET is one injects something. It's often FDG, which is something like glucose, which goes to anything that's active, which could be infection or malignancy. And there's uptake, and the machine then, the computer fuses between these two images and creates the fused image so we can see where there is abnormal uptake. As you can see here in the rib, you see it's for the rib, we can measure it, we can follow. The problem with thymic malignancies is that some thymomas do have FDG uptake, as you can see over here. You see the CT, there's a mass and there's uptake. On the other hand, many thymomas do not have FDG uptake, as you can see here. Both of these were a B2 thymoma, one with FDG uptake, the other without. So the advantage of FDG PET CT that it may highlight areas that were so small that we may have overlooked and show us, in theory, an advantage in staging. The thing is that because you have to have a tumor that's very, very active, so it will actually point things out to you. With thymoma, because so many are not that active, it's not helpful. So then it's not a routine study that we do. Not only that, there are things in the body that show FDG activity that are not malignancy. As you can see over here, this thymus is large and FDG avid, and it's benign. It's something else that's called thymic hyperplasia. So it can be confusing. So because of that, we do not routinely use FDG PET CT for evaluation or for staging or for follow-up of patients. Sometimes it may show an advantage, and I'll tell you in small details when. Let's say there's a very aggressive tumor, a thymic carcinoma, not a thymoma. And we know that thymic carcinomas do show FDG avidity, that we do know, all of them. Sometimes if there's a very aggressive tumor and we need to go into major surgery and the surgeon is contemplating, do I want to do this? It's going to be hard, maybe difficult to recover from. I really want to make sure there's nothing else far away outside that we may have overlooked. That's the only case where sometimes a patient will go to an FDG PET CT scan just as an extra measure, but we know in advance that we're dealing with a type of tumor that will be FDG avid. Otherwise, we don't do that. So we don't routinely follow with a PET CT scan, and we use CT normally and MRI for problem solving, as I showed you before.
Okay, thank you. Next question, how long should post-surgery CT scans be given for, and when is PET scan necessary? So I think about PET, Edith told us everything. How long should post-surgery CT scans be given?
So again, this is based on data. How long do we follow any patient? It can be with any tumor. We look at when does recurrence usually occur? So we don't want it to be too early, because then we see a lot of post-surgical or post-treatment changes and it's confusing. We can call inflammation malignancy. So we wait a while, and it differs 3 or 6 months after surgery, and we get a baseline. And after that baseline, really it depends how aggressive the tumor is. So if the tumor was an early stage, like a stage 1, and it was a complete resection, and let's say it was a type A resection, then it's really up to the surgeon to decide if they want, after that 6-month scan, if they want it on an annual basis or for 6 months, for every 6 months for the first 3 years. But there are general recommendations that for the more advanced stage, or let's say there's something worrisome that was in pathology or in the resection margin, usually the patient will get for the first 3 years every 6 months. And then if there's no recurrence and there's no issues there, on an annual basis. But let's say it was an early stage and everything was resected and there was no recurrence and there's no question, then the general recommendations are that after 5 years, you can alternate between CT and a chest radiograph. But as I said, if patients want, you can also alternate between 1 year a CT, 1 an MRI. But reality is that this is very individualized, because it really depends on how aggressive and how worried the doctor looking after you is to decide. And it'll be more often if there's any question that is seen, anything that we're not sure of, or if the tumor is more aggressive.
Okay, thank you. Given thymomas are considered slow growing, what is the rate of growth, and how long does one think monitoring CT scans should happen for fully resected thymomas given their slow growing nature? So I think, Edith, you answered this question previously, but maybe, I don't know, Arun, Josh, Andreas, would you like to add anything about how long you observe patients, how long you ask for CTs?
Yeah, so maybe I can go first. So as I think Edith pointed out, there is always a risk of recurrence, even if it is low. It can happen over extended periods of time. So in general, long-term follow-up and radiological surveillance is recommended. The question is, what is long-term? Is it indefinite? Is it the first 10, 20 years? Or is there a time limit? To my knowledge, we don't have a concrete sort of time point written in stone. We just decrease the frequency of imaging as more time elapses. And as you heard, you can alternate between imaging modalities. But typically, after 5 years, after definitive therapy, whether it's surgery or something else, you tend to transition to annual scans and then perhaps scans every other year. But as far as I know, there is no recommendation in terms of a stopping point. You just, monitor things for the long term. In terms of the rate of growth, what is the rate of growth? I think, again, that's a slightly difficult question to answer because there's a lot of variability. I think one important thing to point out is, yes, thymomas are considered more indolent than thymic carcinomas, but we have all seen, thymomas that can grow fast and thymic carcinomas that may actually be slightly, may have less aggressive growth. So there's a lot of variability. Therefore, the follow-up needs to be carefully considered for each individual. The only data that I know of which can put some numbers on this is some information that had come out from Japan a few years ago, where they looked at what's called tumor doubling time. So the amount of time it took for a tumor to double in size, essentially. And if we just look at those objective numbers for thymomas, early stage thymomas, it was about 500 days. So that's a fairly long interval, 1.5 years. And for thymic carcinomas, it was about 200 to 250 days. So 9 to 10 months, maybe. So it just goes to show that these can be, these changes can happen over extended periods of time, and therefore the surveillance strategy should also match that biological behavior.
Thank you. Here is the next question about thymoma B1, stage 2A, and clear margins. I had follow-up CTs for 5 years and no radiation. Now my doctor says I only need a CT every 2 years. I feel a bit uneasy about it. Shouldn't I be followed yearly? So it is 5 years was observation, and I understand there's a question about the future. And the second part of this question, I suddenly have 5 nodules on my thyroid. Could thymoma recurrence happen in thyroid? Arun, would you like to answer?
So, in terms of the imaging interval, we talked about it. I think, I think there is some reason to say that it is reasonable to go from yearly surveillance to every 2 years, but it is very difficult to comment on a particular case because it depends on the trajectory of growth previously, a lot of other factors beyond the WHO group, subgroup, and the stage. And I'd love to hear Edith's thoughts about that as well. In terms of the thyroid nodules, the word suddenly makes me a little worried in that statement there. But in general, what I would say is, number one, thyroid nodules actually are not that uncommon in the general population. So if an average person with or without any cancer would undergo a scan, there's a 25-30% chance that the scan would pick up thyroid nodules. That's number one. So in this particular instance, I wonder whether these were new or these were not previously detected because the thyroid wasn't imaged. That question springs to mind. The second point I would make, in our experience, thyroid nodules are seen quite often in patients with thymic cancers. Perhaps I've seen it more often incidentally in scans from patients with thymic carcinoma. But it's very difficult to say, is that higher than the incidence in the general population or not? But suffice it to say that thyroid nodules can be seen quite often in patients with thymic cancers, incidentally, when you get imaging done to look at the chest. We have done biopsies and fine needle aspirates in these cases, and the pathology has been highly variable. So you can have benign conditions of the thyroid, multinodular goiter, that sort of thing. You could have, what are called adenomas in the thyroid. So these are not, aggressive tumors. And you can actually have thyroid cancers, different types of thyroid cancers. But as a general rule, these are all easily treatable. Once you detect it and diagnose it, you do the appropriate surgery or treatment, and these can be dealt with. In terms of the last part of that question, can thymoma recurrence happen in the thyroid? The answer is yes, it actually can. We have had, it's very uncommon, but having said that, we have had instances where these fine needle aspirates from these thyroid nodules have detected basically a histology which is similar to the thymic tumor. So the answer is yes, it can happen, but it's very, very uncommon. And as I said, if these nodules are really new, I think it demands workup and appropriate workup and diagnostic procedures. But the bigger question is, was it always there and it was just detected on imaging incidentally more recently?
And let me just add one thing. Remember when I told you about contrast resolution and how well we see it? So not only is the thyroid often imaged only in part on a routine chest CT scan, also, it depends on if contrast was used on each scan or not, the timing of when the contrast was given, or if the nodules were detected by ultrasound. Ultrasound is the best imaging modality for the thyroid, not CT scan, and if an MRI was seen. So you can understand that in each of these scenarios, the sensitivity of the imaging, yes contrast, no contrast, changes dramatically between MRI, CT, and ultrasound. So that's why if the question arises, a radiologist would have to view all of the images to actually see if they were new or not. And just as a routine, Arun said 25%. We in radiology see them so often, I think it's closer to 100% probably. We don't comment on each nodule in older patients, but it's a very common. And the recommendations are in routine patients to not even start investigation when they're smaller than 1.5 centimeters because they're so common. So, but in patients that have a malignancy and that they're being followed, if indeed they are new, then yes, they would probably start an investigation with an ultrasound, which sees them the best and easy to biopsy under them if needed, but they're usually benign.
Yeah, and for the same reason, from a clinical standpoint too, if you were to see a description from one of our radiology colleagues about a nodule in the thyroid, generally our inclination is to say, okay, let's wait and watch, see how this develops. And most of the time it doesn't develop, it stays the same. But if there is any reason to believe it's acting differently or there are changes, then we follow the workup that Edith just outlined.
Okay, thank you. Another question, type AB thymoma, 7 centimeters in diameter, removed via VATS. And now I have a 1.5 centimeter pleura-based nodule, which has grown, and it is on my rib near where tumor was taken out. Do we biopsy? Watch and wait. If surgery is needed, what type of surgery is needed? Josh, maybe you would like to comment on that.
We don't know the time span, but you may want to, this is a case where the CT, you may want to get a PET scan or MRI to see if there's other lesions, but most likely you're going to go back in and we're going to recommend resection if it's limited defined pleural nodule. And that can be VATS or open or robotic, depending on where the location is and how intense it is. If you go in and it's just one spot, it's actually a relatively small operation. The worry is you go in and you see a lot more spots, but you may not even, Edith can speak to it. There's a certain limit to the visualization that you may or may not see the extra nodules until you go in there with a video scope. But most of us, I believe, are aggressive about re-resecting these as they pop up because it's expected in a small population of patients, especially with a large primary tumor that you had. That's not uncommon.
Okay, thank you. Another question about biopsies. What is the consensus with biopsies? Our doctors are making us have them. I have had 2. Whatever the outcome, the tumor was coming out anyway. What can be done not to have them? My doctor was going to drop me if I refuse treatment. So generally, of course, this question we don't know. It is the question about biopsy before any treatment or biopsy of recurrent tumor or however, maybe Josh, you would like to comment on how, when should be biopsies performed?
This is a nuanced question, and it is in part how some people practice. But I can tell you how sort of I practice, and in general, I think is a fair representation of a lot of surgeons. If it's a relatively small lesion that's going to come out with what we'll call a straightforward thymectomy, minimally invasive. You don't have to take any structures. It's not growing into anything obvious. And it is highly consistent with the thymoma radiologically. Most of us do not do a biopsy, we take it out. As the lesion gets bigger and the surgery potentially gets bigger, like it may be involving vascular structures or other portions, then the risks of the surgery and the complications or the technique of the surgery becomes harder. So we may want a biopsy beforehand to do 2 things. One, to make sure that it's not something like a lymphoma that doesn't need surgery or some other tissue. That's primary biopsy number 1. And then 2, to see if it's a high-grade thymoma that we still may take out, but we may consider giving induction treatment for, say, if it's a B3 thymoma versus an AB thymoma. So my personal sort of paradigm is I also get a PET scan in bigger sized lesions to help guide if they're going to get a biopsy. If it's a moderately sized lesion and I get a PET scan and it's very hot, I'll do a biopsy to help rule out thymic carcinoma versus lymphoma. And that can, because that may change my treatment beforehand. If it's low grade and easy to take out, I won't get a biopsy because I don't think it changes treatment. In regards to you have to just have a discussion with your doctor about, how you feel about their treatment. That's a whole different question.
Okay, thank you. Another question. Insomnia, hoarseness, coughing are often symptoms. How are they related? Who would like to answer this question. I think hoarseness, coughing are depends on the mass in the mediastinum. So maybe Josh, you would like to comment on that?
Insomnia, hoarseness, and coughing certainly can be symptoms of a thymoma or myasthenia gravis related with thymoma that are affecting the nerves to your voice box. The insomnia, if you have trouble sleeping because your voice box is not working, you can't protect your vocal cords, I suspect that could be a little harder to sleep. So they could all be somewhat related, possibly. It doesn't mean they are, but if you had a thymoma involving the nerves to your voice box, these are all certain possible side effects.
Okay. What is the link with autoimmune diseases, of which we have a lot of different ones? How can this be linked together instead of treating everything separately with different doctors? Unfortunately, we don't have neurologists or immunologists in our group, but maybe you would like to comment on this association between thymomas and thymic tumors and autoimmune diseases. Arun, would you like to comment?
Sure, absolutely. So I think there is a well-recognized association between thymic epithelial tumors and autoimmune diseases, of which there are several, as has been pointed out. And our knowledge of this association and the reason this issue arises is expanding by the day. What we know is that in patients with thymoma and also thymic carcinoma to a lesser extent, there are defects in what we call immune self-tolerance. In other words, the body's immune system finds it difficult to determine what is your own tissue, self-tissue, and what is not. And thereby it creates a problem because it starts reacting against, self-antigens, as we call it, against your own bodily tissue. But that does not mean it would affect all tissues. We know that with thymic tumors, there is a predilection for the neuromuscular junction, and that causes myasthenia gravis. But it can potentially involve any tissue, and there are cases of other organs being involved. We have begun to understand the biology of it, and that is an ever-expanding field. There are certain genes that help in determining, helping the body, the immune system, distinguish between self and non-self. And these are altered, in thymomas especially, and that causes this predilection for autoimmunity. In terms of that second question about, I think from a clinical standpoint, what this really impresses upon all of us is that good documentation of, these various medical issues is important. The time frame in terms of when the thymoma was diagnosed and when these autoimmune issues arose is important. And certainly if there's a history of autoimmunity in the family, that should be recorded as well, because sometimes you get little pieces of information from all of this, which might be important. In terms of family members having thymoma, that is a whole different situation. There are certain hereditary conditions in which a thymic tumor might be an observation as well in multiple family members. But generally, it is not considered a hereditary disease. And, we do sometimes hear about, these sort of instances, but that needs to be further worked up and sort of diagnosed and figured out from a biological standpoint.
Okay, thank you. The last part of this question, how can we record our histories, treatment issues, and different family members having thymoma is actually, this kind of question is maybe not medical. If patients are interested to record the histories, for instance, and I don't know for what reason, if, for instance, if you want to record your history and publish on ITMIG webpage, just please contact Pam Bruce. We can think how to organize it. So at this moment, I wouldn't like to spend more time about this topic. Here is a long question, but I would like to summarize it. The question is associated, it's a question about tachycardia associated with thymoma. The patient was operated due to type AB thymoma. Thymus was not removed. After surgery, there was a radiation therapy. And after that, patient developed tachycardia and myasthenia gravis. Currently, patient doesn't have myasthenic symptoms. However, tachycardia still exists. And the question is, have you seen tachycardia before? I could extend this question. How often do you observe cardiac disorders in patients with thymoma? Questions to
some extent. I mean,
yes.
Anytime you operate around the heart, and particularly the pericardium, especially perioperatively, and I suspect also with some radiation, you can get irritation to the myocardium, and it can cause tachycardia or arrhythmias. They're usually not long lasting, the surgical effects, and you need to rule out other cardiac causes when something happens like that. You can't totally assume that it's sort of post-operative changes or irritation.
Mm-hmm. Do you observe the question to all of you? Do you observe tachycardia or cardiac disorders not associated with surgery, but maybe associated, maybe as a, I don't know, paraneoplastic syndrome associated with thymoma? Do you recall such patients?
It's very uncommon. So if you look at the data on the data on autoimmunity affecting the heart in patients with thymoma as a paraneoplastic condition, the incidence is less than 1%. It's very, very uncommon. Cases of myocarditis have been described, and that may not necessarily present just with tachycardia. You know, there would be far more sort of widespread symptoms associated with it. So the short answer is it can happen, but it's very uncommon. Mm-hmm. From a medical oncologist standpoint, have I seen patients who come to see us, having tachycardia, which a heart rate which is higher than their baseline before diagnosis? The answer is yes. We often see that, not usually in the 140s, heart rate in the 140s, but something like the 90s, 100s, whereas prior to surgery or diagnosis, they might have been in the 70s, for example. So we see it often, and most of the time it is not symptomatic. It's an observation when you examine the patient. But as Dr. Sonett mentioned, it is important to not just assume it's related to the thymic tumor or surgery. Because if there are any other, if there's any history suggestive of maybe primary heart disease, the appropriate workup needs to be done.
Okay, thank you.
I think maybe this is a good just thing to mention that knowledge of the relationship between the heart itself and the group of thymic malignancies is extremely interesting. And we don't have any cardiologists in our group right now in this conversation here that is present. But in our annual conference, I do recommend that you join, because we were able to find, and it was difficult, a cardiologist that has a special interest in that. And he will be talking about that. It's very rare to find doctors that specialize in that.
Yeah, that's right.
Thank you, Edith. Yes, it's very important, and I think it will be very interesting talk. Next question: how long is the life expectancy for stage 4 thymic carcinoma patients?
Yeah, so this is again a question. The answer would be quite nuanced, because it depends on the particular individual, the stage of the tumor, the subtype of thymic carcinoma. I mean, a lot of other, completeness of surgical resection, if it was operable, etc. So there are a lot of factors which go into it. I think in general terms, one could say that stage for stage, if you compare even the more aggressive thymic tumors, which are thymic carcinomas, the prognostic information, the life expectancy figures are actually better than what you would expect with very aggressive cancers like lung cancer or pancreatic cancer. That's a general sort of statement. Again, if you want to look at objective data, ITMIG just published a very nice review, comprehensive review on thymic carcinomas, I think within the last month or so. And when you look at all the data and put it together, what you find is that the average survival across the board, for thymic carcinoma is in the order of 6 to 8 years. And again, there's a lot of variability in it depending on, several other factors. And if you look at, the landmark analyses, as we call it, 5-year overall survival, for example, it's 55 to 60%. It's a fairly high figure. And the silver lining in all this is those numbers are continuously improving because of improved ways to treat these cancers. Greater recognition, it's picked up early, you treat it aggressively. So these numbers are always improving. But those are the numbers as of today.
Thank you. And the next combined question. At the beginning, what is the long-term prognosis? So again, a question about prognosing survival of different thymoma, type A, AB, and so on, and the recurrence rate of various type of thymoma. Arun, you were talking a lot about it. Would you like to add anything?
Sure. So as far as thymomas go, again, there's a lot of histological variability. And as I said at the outset, we have all seen patients who have supposedly what is supposed to be an indolent tumor, but it behaves aggressively. So you really have to be cautious and manage according to what the tumor actually behaves like. But in general, again, the subtype of thymoma does have some bearing on the long-term outcome. Type A and AB are associated with very good outcomes on average. So if you look at the 10-year rate of relapse, it would be in the low single digits. 10-year overall survival would be upwards of 85% or so, upwards of 90% probably. When you look at B1, B2 thymomas, that same 10-year overall survival would be in the range of 70 to 80%. And then when you go to B3 thymomas and thymic carcinomas, those numbers drop a little bit. But again, overall, long-term survival and a good quality of life can be expected in several individuals with thymoma. What is the recurrence rate of different types? As I just mentioned, for A and AB, it's less than 10% at 10 years. For B1 and B2, it's probably in the 20% range. For thymic carcinoma, it's probably about 50% or so. But again, these are just individual factors, based on the WHO group, because equally important, if not more, is what sort of surgical therapy was offered initially. Was it a complete resection? What is the stage, very importantly? These have a bearing on the rate of relapse as well. The third question is actually fairly easy to answer. And I think it brings into focus the fact that, unfortunately, there is this misconception that some thymomas can be benign. And the answer is no thymoma is benign. They're all malignant. The only question is, what is their clinical behavior like? Some are more indolent, some are more aggressive, but they're all malignant. At the beginning, later on, it's really what the case is. In terms of second cancers, yes, there are epidemiological studies, population studies from various countries, which have shown an increased risk of developing second cancers. But again, these are population studies which will not tell you necessarily about causation versus correlation. It is an observation that the risk is slightly increased. There are different types of cancers, that have been observed. And the risk is low. It's not that one should worry about, getting a second cancer 5 years from diagnosis. The percentages are actually quite low. But is it possible? The answer is yes. And it, again, is probably related to this defective immune surveillance, which exists in a situation where there is a thymoma. And that could prevent surveillance and clearing up of, second cancers that might develop. That's one of the thought processes. And then maybe, Margaret, I'll defer to you for the fifth question. But in terms of the genomic and molecular profiling, what I would say is, from a clinical standpoint, the short answer is it is not as clinically relevant for thymic tumors as it is for, let's say, lung cancer. for a few reasons. Number one, the rate of mutations as such is low. And number two, the rate of what we call targetable mutations, for which there are drugs that you can use if there is a particular mutation, that's very low as well. So generally, molecular profiling, it's done as a matter of, completing the workup. I've seen it done, but often it does not yield clinically relevant information. And certainly in the frontline setting, it is not relevant because perioperative treatment, whether you're doing treatment before surgery or after surgery, at this point, it does not incorporate targeted therapy towards certain genes or immunotherapy for that matter. So it's all based on chemotherapy. So it is not not useful in that circumstance.
Mm-hmm. Thank you, Arun. In terms of the fifth question after thymectomy, is it advisable to get a second opinion on the pathology report? I think it's not a decision of pathologist, it's a decision of clinician actually, or maybe patient, but what from my point of view, from point of view of pathologist. So if the report was, if the case was analyzed by experienced pathologist, experienced in thoracic tumors, it was a thoracic pathologist. I think it's not necessary to have a second opinion. However, in my opinion, in all cases, if there is any discordance between clinical data, radiological data, and pathological report, it may be good to consult, to ask another pathologist about their opinion. Usually pathologists, frankly speaking, do the same if they have any doubts because the diagnosis they want to write that is not in accordance with, let's say, radiological data, clinical data, they usually consult the case. However, sometimes they don't. So if there is any problem, maybe such a second opinion would be helpful. And according to my experience, I also suggest second opinion. Sometimes I notice that pathologists who are not very experienced in thoracic tumors, thymic tumors, they don't prepare full reports. I mean, there is only, for instance, histological subtypes, a thymoma type, it doesn't matter. For instance, there is no information about surgical margins in the report. In such situation, it should be also a second opinion if there is any possibility to complete this report about, let's say, surgical margins or stage. And only short comment on the sixth question, Dr. Rajan answered, I agree absolutely. From my point of view, for my report, there is no genetic tests that are recommended routinely for diagnosis of thymic tumors. There are tests that can be helpful. For instance, let's say analysis of such a gene named GTF2I gene. This gene, mutation in this gene is more common. Let's say it type AB thymomas. However, it is not specific mutation, and in routine, for routine diagnostics, for routine pathology, such test is not recommended. And frankly speaking, there is no molecular test or genetic test recommended in routine pathological diagnostics. Next question again, what is the known survival rate from thymic carcinoma? I think we can skip this question. What is judged to be the most successful method of treating thymic carcinoma? The question is concentrated on thymic carcinoma. Would you like to add anything? The most successful method of treating of thymic? I think it's very complicated, it depends on the stage, but maybe a short comment.
Surgery whenever possible.
Yeah, I was thinking again the same.
Agreed, and radiation has a presumably slightly greater role in thymic carcinoma. I think most of us would lean more towards offering radiation even after complete resection.
Is there any record of use of the new lung cancer wonder drug being used successfully to treat thymic carcinoma? So Arun, I think this time to you.
Yeah, so I'm afraid I'm not really sure which drug is being referenced. It's very satisfying to see that for lung cancer, there have been several new targeted therapies which have been developed. If the question relates to any of those targeted therapies, which target certain gene mutations or, gene changes, the answer is no. There is no record, and it's simply because those mutations don't exist in, thymic carcinomas or thymomas for that matter. If the question is related to immunotherapy, pembrolizumab and such, yes, patients with lung cancer and several other cancers for that matter benefit from it, including thymic carcinoma. But a couple of points to remember is that it gives durable benefit, these immunotherapies, for a subset of patients. In the case of thymic carcinomas, that number is about 25%, where there are objective responses. So there's a lot more that needs to be done to figure out why others don't respond, why they have resistance, and so on and so forth. And again, if that wonder drug is Keytruda or pembrolizumab that's being referenced, I think we all mention it at every available opportunity. In patients with thymic cancers, including thymic carcinoma, the risk profile is extremely different, night and day, from lung cancer or anything else, because of this propensity to autoimmunity. And severe autoimmune toxicity can occur. So one has to be extremely cautious when using these drugs, these immunotherapeutic drugs. Many of us say use it in the context of a clinical trial if it's available, because monitoring is very close and so forth. But even if it's used for general standard of care use, I think the management paradigm, the follow-up, attention to potential side effects has to be much, much greater, and very close follow-up is recommended in these instances.
Thank you so much. And now I have a question to all experts, to all doctors, because actually we should finish our webinar. Do you have, let's say, 10 minutes? Could we extend our webinar for, let's say, 10 minutes? Is it possible for you?
It works for me.
Great, thank you. So let's go further. Thymoma is generally regarded as slow growing. If you have recurrence of thymoma, is it also classed as slow growing, or it is more aggressive? Before you answer this, I can tell you from my point of view, pathologist. So when I see recurrences, they usually are very similar to the primary tumor. However, sometimes there are very slight changes. For instance, at the beginning it was B2 thymoma, but recurrent tumor B3 thymoma. So usually the same tumor. However, sometimes we can see that tumors that represent the type with lower number of lymphocytes. So sometimes treatment reduces the number of lymphocytes, and then the tumor is more similar to the other type, usually with a lower number of lymphocytes. But such situations are not so often. However, if the primary tumor was combined tumor, let's say B2, B3 thymoma, in recurrent tumor, I can see, for instance, only one of these components. So it was from my point of view. So what is your observation, clinical observation?
From a medical standpoint, a medical oncology standpoint, I completely agree with you. We have also seen uncommonly, we have seen instances where the histology went from less aggressive to more aggressive, and that correlates with fewer lymphocytes, because then you're talking about a B2 which looked like a B3 or a thymic carcinoma and so forth. So it's uncommon. I've not seen it very often. And sometimes this correlates with clinical behavior. So for example, the tumor was behaving in a certain manner and growing at a certain rate. And after several years, we have noticed in very rare instances, the rate of growth, either it picks up, it becomes more, patients develop more symptoms. When you repeat scans at a fixed interval, you see more growth, more volume of tumor. And sometimes that is actually, we do a biopsy to see has anything changed. And that has sometimes correlated with this observation of the pathological change, histological change. But that is not very common. It's more, it's not very common at all from my perspective.
Okay, thank you. Again, thymomas are slow growing. Would a thymoma measuring about 7 centimeters grow much if left untreated for 9 months? I haven't seen my mom for over 2 years due to pandemic and want to have treatment delayed. 9 months of delay, in your opinion?
Yeah, again, 7 centimeters, it's a fairly large tumor. I think most of us would say it's unfortunate, that the circumstances with the pandemic have been such that it has really altered so much. But I think one would be a little bit hesitant to say, let it go for 9 months when it has grown to that size. There are factors which play into that reasoning. Location of the tumor, could it be a tumor that's potentially operable and it becomes inoperable because it grew more in that time frame? There's always a risk of spread, so that can make the tumor what would otherwise be more treatable. It may make it less so. So I think personally, from my perspective, I would say for a tumor of that size, I would say maybe it's not a good idea to wait 9 months without any follow, at least at the very least close follow-up to make sure it's not changing, but it probably needs treatment.
Agreed. I mean, as noted, these are not benign. So unless that person has significant other medical issues that make surgery prohibitive or any other treatment prohibitive, it behooves everybody to take care of it because it's only going to get worse.
Okay.
Agreed as well. And if surgery is if surgery is not possible for some reason, then actually radiation therapy can be used as the definitive curative treatment in these situations, sometimes in combination with chemotherapy. So there are treatment options even aside from surgery if for some reason this should not be an operable person.
And Andrea, the size of the tumor obviously matters, isn't it? The larger it is, the more difficult it is to give definitive radiation without much toxicity, right?
Yeah, most thymomas arise in the anterior mediastinum, meaning in the front of the chest, right behind the breastbone. That luckily is a relatively silent area and relatively easy to treat, even when they are, somewhat sizable. I think the factors that do make it potentially more toxic in terms of side effects are how far back it grows, because that would bring it closer to the esophagus or the trachea, the windpipe, and also how far inferior, meaning further down it grows, because then you get close to the great vessels, the heart, the coronary arteries. So those are some of the structures that would be more worrisome if it was growing in that direction. But in general, radiation to that area is relatively easily tolerated, and certainly is not something that we would just forego because of concerns of toxicity.
Okay, thank you. I'd like to know if all thymomas are cancerous. My husband is getting his thymoma B1 stage 1 removed today, and the doctor keeps telling us that's benign. I think we responded to this question, but maybe it would be good to highlight once again, all thymomas are malignant. Any comment, or we can go further?
Absolutely agree.
Okay, so let's go further because of time. Question about association between gender and thymomas, because is there a difference from my own observation and talks with friends, thymoma support group? It seems to be more common among women versus men. If so, possible reasons? Are there any major variables that we currently know about when it comes to thymoma stats? Also, I have some literature I've read. It suggests that estrogen inhibits the growth of thymoma cells. I would assume it would be less common among women if estrogen plays a role of inhibiting. Any comment of association between thymomas and gender of patients?
Yeah, this is actually a very interesting question. And I have to admit, I had to look this up a little bit in terms of the preclinical work which has been done in this regard. So I would say from a clinical standpoint, in terms of, thymomas, the type of thymoma, the stage, in men versus women, we don't really see major differences, and there are certainly no differences in terms of the treatment paradigm when you look at men versus women. But there are some studies out there, and these are all preclinical studies in animal models, etc., which suggest that there are some differences, sex-based differences, hormonal differences in terms of the impact of these sex hormones on thymic aging, thymic involution as a natural process. And its effect on what are known as thymic epithelial cells, the type of cells that turn malignant. So there are differences which have been described because of androgens, testicular hormones, which can cause some of these epithelial cells to sort of survive longer, but they don't necessarily proliferate and divide, at a fast rate. And then there are some such observations in the effect of female sex hormones and its effect on the various cells in the thymus. Some of these studies have shown implications more in terms of the risk of autoimmunity, because autoimmune conditions are observed to be more common in females than males, and maybe the risk of infection. But none of these studies, to my knowledge, shows any direct implication in terms of developing a thymoma or how aggressive it might be, the thymic tumor, and so forth. And as I said at the beginning, from a clinical standpoint, there are no differences that we have observed.
Okay, thank you. Are we close to a gene link? I think, Arun, you answered this similar question, so maybe let's go further. Here is again a question about whether thymomas are inherited tumors. It was a case of someone who died due to thymic tumor. Actually, we don't know exactly what type of the tumor was. And are there any recommendations on lifelong screening, monitoring of the children of such person?
Yeah, first of all, we are all very sorry to hear about this case. It's most unfortunate. I would say in general, in terms of screening, I think most of us would agree there is no role for screening in the setting of a thymic tumor, because in general these are not considered hereditary conditions. There are certain exceptions to that rule. So, for example, there is a syndrome known as multiple endocrine neoplasia, MEN1, and thymic carcinoids can be seen in multiple family members and in that sort of situation, in addition to other tumors that characterize this MEN1 syndrome. And then we have seen very few families, but we have heard of instances where more than one family member might have had a thymic tumor. But again, when we look at the genetics, the genes, and do some of these analyses, there isn't any clear-cut explanation so far as to why more than one family member was affected. It brings into question whether there's some other cause, some environmental cause. It's really not known. But in terms of recommendations, outside of something which is recognized like MEN1, for example, we don't normally recommend screening.
Okay. Thank you very much. I'm afraid we have to finish our webinar. Time is over. Thank you for all fantastic questions, very important questions. I would like to thank all of you, all our experts who responded to these questions. So thank you once again. Thank you. Bye.